So till now we have talked about the full crowns. Full crowns means we are encircling whole of the teeth and giving a crown on top of this. In this lecture we will be talking about porcelain veneers. So veneers are the one that covers only the facial surface. You can see this is the lingual area. You can see the lingual aspect, and from there you can appreciate that it is only encircling the facial surface. So these veneers covers only the facial surface. It is a cap that encircles or that covers only the facial surface. So for aesthetic, we use this porcelain veneer. Suppose if a person is having intrinsic stains, if you want to correct that, if the patient is having slight amount of diastema, you can correct it using that. So the smile correction or the coloration correction can be done using the porcelain veneer crown. So basically it covers the facial aspect of the teeth. There are direct veneers and indirect veneers. Direct veneers are the one that are the composite veneers. Indirect veneers can be composite, acrylic resin, porcelain, or the gold one. So if the patient has erosion palatally, gold can be used to cover the palatal surface and reduce the sensitivity, or gold can also be used on the lower anterior teeth if the patient doesn't mind the aesthetics. So before starting with a composite veneer, let's see how a veneer is. So this is a porcelain veneer crown. You can see the porcelain veneer crown is just the crown that covers the facial aspect. It is like covering with the tooth like an artificial nail. So before you are putting an artificial nail, we prep the nail. Likewise, we prep the tooth. So we do a minimal amount of tooth reduction. And you can see that we have to create a fine line, that is the finish line. And then we start etching the tooth and then we put the veneers. So that gives a good aesthetic. Or if there is a crooked teeth, broken teeth, then also we give veneers that covers the facial aspect. Then we cure it with a composite resin. So this is how a veneer is. It is just the cap that covers the facial aspect. So it covers only the facial aspect of the teeth. Advantage of using veneer is that it is simple, quick, and there is no need for lab work. And disadvantage is that it gives a monochromatic appearance. All the teeth look similar. It requires high skill because we only need to cover the facial aspect and we need to only remove the enamel part. It is a time consuming process and cannot mask a deep coloration. If there is deep coloration, then we need to remove more of the tooth structure, and we do not want to do this. So coming to the indications of the veneer, which all situation we give veneer. In case of a mild discoloration, we can give. If there is a deep discoloration, we cannot use the veneer, because for deep discoloration, we need to remove more of the tooth structure. And the main focus of this, the main agenda of the veneer is that it does the minimal tooth preparation. So the conservation of tooth structure is there. But if there is a deep coloration, then we need to remove more of the tooth structure. So that is why for mild discoloration, we use the veneers. Then for mild spacing, we use for deep discoloration, otherwise the tooth will be over contoured. That is why we do not use it. For mild spacing and malalignment also, we use the veneer. For small diastema closure or the tooth wear. So for cases of the diastema, like there is a small amount of diastema, it can be closed by the partial veneer, very technique sensitive process. And it is difficult to place, and you might break them while you are placing it because they're very thin. So you can also use in case of midline diastema. Then hypocalcifications, you can use the veneers, and correct lingually inclined teeth, you can correct it using the veneers. The contraindication, the situation wherein you cannot use the veneers, is heavy discoloration or fluorosis. It will resist the etching process also. So poor oral hygiene and high caries risk, we cannot use veneer. In case of mouth breather, they have constant wetting and drying of the labial surface. So stresses comes on the veneer and they are more susceptible to caries. That is why we do not use veneers in case of mouth breather. Bruxism or edge-to-edge occlusion or crossbite, because there will be excessive forces coming on the stress point. So that is why we do not use. And for labially inclined teeth, we do not use. For lingually inclined teeth, it is the indication to use a veneer. So lingually inclined teeth, we do give veneers. And labially inclined teeth are contraindications for the veneers. So for lingually inclined, we use veneer. For labially inclined, we do not use veneer. Then how about the preparation? So we take a wheel burr and we make the indentation, we make the depth orientation grooves. So veneers should remain in the enamel only but provide enough thickness to the porcelain. So we make a preparation of 0.5 millimeters onto the enamel. There should be no undercut, no sharp line angles, and there should be enough interproximal clearance to place a miler step between the adjacent teeth during the bonding process. Any visibly accessible area should be covered with the porcelain, and LA is given after we do the shade selection. First thing, you do the shade selection, then you proceed with the process, because LA might interfere with the shade also. So we start with the facial reduction. You can see we have three wheeled diamond burr. So these are the burrs that are used for porcelain. In that there are 3 wheels in a burr. And we also have these we create this depth orientation groove. So these are the depth orientation grooves that we provide. These depth orientation grooves are done on facial aspect different, lingual aspect different. The cervical aspect different and the incisal aspect different. So gingivally or cervically, we create depth orientation groove of 0.3 millimeters. And incisally, we create depth orientation groove of 0.5 to 0.7 millimeters. So it is more in case of the incisal area, because there are less chances of damaging the pulp, since as we go incisally, pulp is not present. So when we go incisally, we create more reduction. Then the wheels on the burr do not have the same diameter. So the wheels are used cervically is narrower, that is 0.6 millimeter diameter burr, and the wheel that used incisally is different. So the burr that we use cervically is the one that is 0.6 millimeter diameter burr. So you have to go to the half of the burr. If it is 0.6 millimeter diameter, so if you go to half of this burr, you get 0.3 millimeter of the depth orientation groove. The one that is used for incisal, it is 1 millimeter diameter burr, and this burr, if you go to half of this burr, it will create the depth orientation groove of 0.5 millimeter. So this is how we have different diamond burr, wheel diamond burr for the incisal area and different wheel diamond burr for the cervical area. So the diameter of these burr are different. The diameter for cervical area is 0.6 millimeter diameter burr. We go to half of the burr and we make a depth orientation groove of 0.3 millimeter. For 1 millimeter burr, that is used for incisal area, and this burr, the incisal area, and this burr creates a depth orientation groove of 0.5 millimeter, because we are going only till the half of the burr. If you don't have a 3-wheeled diamond burr, you can also use a diamond burr of 1 millimeter diameter and sink it into the half. So it will create 0.5 millimeter of the reduction. So after making the depth orientation groove, then connects the groove using a round end tapered diamond burr. You connect it and then connect the grooves. As I told you, make sure that you have 2 plane reduction like what we did for the full crown preparation. So you always need a finish line, because the technician needs to know that where the restoration ends. So finish line is either a knife edge or it is a chamfer margin. You might not always do the facial reduction, but make sure you always create a finish line so that technician knows that this is the starting point or the end point of the crown preparation. Then we do the proximal reduction. The extension of the facial reduction, it should not break the contact. The proximal reduction should not break the contact between the teeth. If this is the contact point between the 2 teeth, the proximal reduction should not break the contact point. If you break the contact point, then it is harder for the patient to clean the margins. It may cause the tooth movement while you construct the veneer. So you need to temporize it. And also it can create undercuts if the path of insertion is labial. Where in situation you need to break the contact point. So there are 4 situations wherein you need to break the contact point. Normally in case of veneer, we do not break the contact point. But there are 4 situations in which we break the contact point. So the first one is the peg-shaped lateral teeth. The technician needs to build up the shape of the lateral, so we need to break the contact point, and already the tooth is very small. In case of crowding also we break the contact point. In case of diastema we break the contact point, and minor class 3 restoration you need to end on the sound tooth structure. So these full situation, we break the contact, but otherwise in normal scenario, we do not break the contact while we are doing the proximal reduction. Coming to the incisal reduction, that means the reduction that we are going, we are not breaking the contact between the two teeth. This is the meaning of breaking the contact point. That means we are not breaking, we are not separating the two teeth. There is no gap between two teeth. The tooth remain intact proximally. That means they are not, the contact point is not broken. So coming to the incisal reduction, now we have different scenarios for incisal reduction. Either we cover the incisal reduction, the incisal edge, or we do not cover the incisal edge. So based on that, we have different kind of designs of the tooth preparation. So the first one is window veneer preparation. In the window veneer preparation, you can see that veneer is taken close to, but does not include the incisal edge. So the veneer is, this is the facial aspect, and it is not covering the incisal edge. It is excluding the incisal edge. So the advantage of using this preparation is that it retains the natural enamel on the incisal area. It is used when the occlusion does not allow you to extend your preparation palatally. So the incisal edges, then if you are not removing the incisal edge, the preparation will be like this, right? This is the veneer that you are going to use. Now the incisal area becomes very thin and it becomes prone to fracture. So that is the reason, that is the disadvantage of window veneer preparation. Coming to the next design, next one is the feather. So for feather preparation, the veneer is taken up to the incisal edge, but the edge is not reduced. So further from the window veneer preparation, so in the window veneer preparation, we extend this window veneer preparation, and that becomes the feather preparation. So this feather preparation, the veneer is taken up to the incisal edge, but the edge is not reduced. So the advantage is that anterior guidance remains on the natural tooth structure, but the veneer become more prone to fracture at the incisal edge. Now remember this thing, that incisal edge is also weakened in case of the window veneer preparation. As I told you, the incisal edge is weakened because we have left the incisal edge in the natural teeth, so it is difficult to hide the cement incisally. In case of this window veneer preparation, cement will be visible actually. So the normal people will come to know that this is a fake teeth or this is a crown that is placed on top of this. So that is why we have come up with the more aesthetic option, that is the feather preparation. But still, again, in case of feather preparation also, the veneer is more prone to fracture because of the thin incisal edge. Path of insertion for both, for the window veneer preparation and for the feather preparation, when you are inserting it, the veneer should stick labially. So you are sticking the veneer labially for both of these, because you can just stick on that. Say suppose if this is the veneer and this is the tooth, and you have done the facial reduction or the buccal reduction, you can just stick the veneer onto the tooth. So you are going labially when you are placing the crown. So the path of insertion becomes labially. Then coming to next design, which is incisal overlap. Now, as the name suggests, here incisal overlap means the incisal edge is also reduced, and we are placing the incisal edge in the veneer. So incisal edge is reduced and veneer extends palatally, the finish line cervically, and there is a finish line palatally also. So there are two finish lines, one palatally, another one is cervically or facially. Now, because there is no thin incisal edge in the natural teeth, we have removed the incisal edge. So this becomes the strongest preparation design. This is the strongest preparation design, and it is indicated when you need to increase the length of the teeth, the junction of the porcelain and the natural teeth. It should be 1 mm away from the centric contact. So you need to see the centric contact, and that contact should be 1 mm away. The junction of the porcelain and the natural teeth should be 1 mm away from the centric contact. Advantage of using this incisal overlap is that it provides a positive seat for cementing, and the disadvantage is that it is more aggressive and you need to modify the path of insertion for the veneer. Why you need to modify? Now here, since the incisal edge is covered, if you see the situation, like this situation in which the incisal edge is also covered in the veneer. You cannot just place labially. You cannot just place labially because you need to cover incisal edge also. So you need to place the veneer like this. So for the path of insertion for this veneer becomes lingual when you are doing the upper anterior teeth. So the path of insertion changes in case of the incisal overlap design. Now that becomes a disadvantage. Now coming to the lingual reduction that we do. Lingual reduction is 0.5 millimeter chamfer line that is located 1/4 down the lingual surface. So it is 1 mm away from the centric point. If this is the upper anterior and here is the lower anterior, and if this is the contact point. Now if this becomes the contact point, so the preparation, the veneer that you are giving, if this is the veneer design, it is 1 mm away from this contact point. So that you need to see when you are doing this incisal overlap reduction. The position of the lingual finish line will also depend on the thickness of the teeth and the patient occlusion. So extending it lingually will increase the surface area for bonding, and it also increases the retention because we are increasing the surface area. Path of insertion, it becomes a hinged path. The path of insertion, it becomes the lingual. So under the inside, because you need to place this veneer under the incisal edge. So then you need to rotate it towards the facial surface. This is done to prevent the over reduction of the gingival 1/3 area. And if the path of insertion was incisogingivally, then gingival 1/3 need to be reduced more. Now see the impression technique. First you place the retraction cords, then remove the retraction cords and take the light body impression material. So after you place the light body impression material, then you take the heavy body or putty consistency and place the tray, and then the impression that you get is light body around the teeth and the impression is heavy body. So this is the impression that you get. First you need to place the retraction cord. After that, once you remove the retraction cord, we get a really nice finish line, and on that you put the light body material, and in the tray you load the putty material. So then tray you load the putty material and then you get the impression. This is really nice impression for the veneers. So coming to the impression technique, the first thing you need to do is placing the retraction cord, then remove the retraction cord and take the impression with the light body first, and then take the impression with the heavy body. Load the tray with the putty or heavy body. Usually there is no need to temporize after the veneer. Temporization is done only if the teeth are sensitive to exposed dentine. You did incisal reductions, especially in the lower veneers. You are replacing only one of the many veneers and there is multiple preparation, or if you have broken the contact, all these things you need to temporization. Now what is temporization? Temporization is giving a temporary crown. Once your veneer, porcelain veneer has come from the lab, then you need to place it on the patient mouth. But this is a process in which you take the impression, you give the impression to the lab, and you get your final veneers. Now this process may take 2 days, 3 days of time, or maybe more, or it may come in 1 day or 2 days. So time being, meanwhile, you need to give a temporary crown to these veneers, and this process is known as temporization. Spot etching is when you etch only at a single place. So see, this is spot etching that we are doing, and you just place a spot of the etch, otherwise you won't be able to remove the restoration. So you have to, this is the spot etching. After that, you are bonding with the agent and then curing it, applying the bonding agent and then curing it. This is only done in single spot. You have not etched in the complete area. Then you are placing the light cure resin, and you have placed the resins, the light cure resin, or you can also use a chemical cure resin. So this is a chemical cure resin that we have used for temporary crown. Self cure resin is used, and you have removed the excess part, and do not push it. You need to just take it out. If you push it, it won't stick. Remove the extra, and then you need to polish it with the help of a composite polishing burr after you remove the extra. So this is how we place the temporization for the veneers. then polish it. So that's the temporization technique. Spot etching, only etching at a single spot. Mostly we do at the center of the teeth. You can place just a spot of the etchant, otherwise you won't be able to remove the restoration. And the spot etching is done with a free hand, or you can use a vacuum tray or a silicone index for that. That means the putty index you can also use, but we do it free hand. And you have to trim it, changing the previous preparation. So veneers for the lower anterior should have the incisal overlap to overlap the risk of over eruption. The composite spots are placed on the palatal surface of the opposing teeth, so that we know this is the point where we have placed the crown have higher incidence of caries. Veneers have the high aesthetic potential because they preserve the optical properties. So basically, during the try-on of the veneers, if the shade is okay, you can go ahead with a clear resin cement. And if you need to adjust the shade, this is when we are giving the final crown, then you can try the chemically cured resin cement until the color is acceptable, then remove the veneer and then clean it with the acetone. So the final color of the veneer will be 90% from the porcelain color, only 10% will be of the cement color. Coming to the bonding or cementation, this is similar to that we have done in the temporization, but instead of spot etching, we completely etch the surface. So we place a rubber dam mylar strip in between the teeth to prevent the resin from sticking together. We place the Teflon tape on the adjacent teeth, and then this is to protect from the etchant. Then we clean the preps with the pumice or the polishing paste and rubber cup. So before you place a final veneer crown, you need to clean the area with the pumice or with the polishing paste. Then we etch the complete area with 37% phosphoric acid, and then we apply the bonding agent. We need to air thin it and not cure it. If there is any bleeding during the cementation, then stop the process and postpone it to another day. Etch the veneer fitting surface with the hydrofluoric acid. Now we have etched the tooth surface that we have prepared with a 37% phosphoric acid. Apart from the tooth surface, we also need to etch the inside part of the veneer. So inside fitting surface of the veneer with the hydrofluoric acid, and we need to wash it. And then we apply the silane coupling agent and air thin, and then apply the bonding agent and air thin it, air dry it. Then we apply the resin cement onto the veneer. So this is the process that we do on the veneer. And this is the process that we do on the teeth. So first we need to etch the veneer, then apply the silane coupling agent to the veneer, then air dry it, and then apply the bonding agent, and then also air dry it. And later on, after we do these three steps, then we apply the resin cement on the veneer and then place it on the preparation, cure it for 3 seconds, remove the excess cement, then properly cure it for 60 seconds. And this is how a resin cement porcelain veneer crown is placed onto the teeth. And you can also use the dual coat composite resin, and it is mainly used in case of restoration which is outside the smile line, restoration more than 0.7 millimeter thick, or for opaque veneers. Once you are placing this veneers, you can use the micro brush, sticky micro brush, so that the veneers sticks to the tooth perfectly. So then we finish with the help of a diamond burr or the polishing strips or disc, then the diamond paste and the rubber cup, and this is how a porcelain veneer crown is given to the patient.